Welcome everyone to the Solving Kids Cancer UK's Neuroblastoma Parent Symposium 2026 and the third of its six-part webinar series. Today's session is titled BEACON2, Expanding Treatment Options for Relapsed Neuroblastoma. My name is Alan Pearson and I'm a parent advocate, and it's my pleasure to be moderating as well as presenting in this session alongside Professor Juliet Gray, Professor of Paediatric Oncology at Southampton Children's Hospital. Before we begin, I'd like to draw your attention to the Q&A function at the bottom of the screen. Here you can submit questions at any point during the session. There's also an option to submit questions anonymously and to upvote questions you'd like to see answered. We'll come to the questions after all of our presentations have concluded. And now we move on to the presentation section. I'd like to briefly share with you what my role as a parent advocate involves and how it has evolved over time and how it's led to my involvement in BEACON2. I'm a bereaved parent. I lost my daughter Tina to relapsed neuroblastoma when she was 9 years old. During her 6 years of treatment, I learned to speak up for her needs, her care, and to ensure that she had options. Today, I use that experience to stand alongside other families and much more experienced advocates on behalf of children like her and to help parents feel informed, supported, and heard. One of the first aspects of advocacy for me was learning how to use my voice more effectively. I have a science background, but even with that, the language used in clinical research and clinical trials is complex and it's highly specialized. So staying current and understanding that language and helping to translate that into something accessible for families became an important part of my contribution. As my involvement increased, my role expanded to support discussion at both national and international levels. This included engaging with medical teams and research institutes and developing an understanding of how our research priorities and drug funding decisions are made. These are areas where parent perspectives are often underrepresented, despite being directly relevant to the patients and their families. As part of my advocacy work, I represent the patient voice. That means ensuring quality of life is considered along clinical outcomes, that clinical data is interpreted in the context of the real family experience, and that the fact that the patient is a child remains central to decision-making. Clinical trial support has become another key part of my role. This includes assessing value from a participant perspective, supporting appropriate ethical standards and oversight, and contributing to the development of clear lay summaries so families can actually make informed decisions about what they're participating in. Through this work, I became chair of the Patient and Public Involvement and Engagement Workstream for Childhood Cancer Ireland. And that path ultimately led to my involvement in BEACON2, which is a multi-arm, multi-stage platform trial for relapsed neuroblastoma, which you're about to hear about. Within BEACON2, I serve on the trial steering committee as a participant advocate. In that role, I hope to help monitor trial progress, review adherence to protocol, consider amendments, and contribute to recommendations. Most importantly, my role is to represent the rights, safety, and well-being of the children and families taking part in the trial, and to ensure that new information is considered from a participant perspective. For me, this journey reflects how personal experience, when combined with structured engagement, I hope can contribute meaningfully to progress. It's also important for me to say that the advocate community is not only where I contribute, but it's also where I find a lot of support after the loss of Tina. I hope this has given you an insight into the background, role, and value of parent advocates. Thank you for listening, and that concludes my presentation. I'll now hand you over to Professor Gray, who will share information of the BEACON trial, including key details on the potential side effects and the future arms. Over to you, Professor Gray.
Thank you very much, Alan. It's a real pleasure to be here this evening and to share the BEACON2 trial with people. So what I would like to do over the next 20 minutes is to talk about why we need the BEACON2 trial, some of the challenges of relapsed high-risk neuroblastoma, what current strategies we have for treating relapsed neuroblastoma, and then to describe the current format of the trial and what we see in the future over the coming months and years. So I think that everybody probably is in agreement that we need better treatments for relapsed high-risk neuroblastoma. everybody knows that high-risk neuroblastoma is a really challenging, difficult disease. And unfortunately, around 50% of children will relapse despite the very intensive treatments that we give them. Outcome at relapse is poor, but it is improving, and it has over the time that I've been a paediatric oncologist. I've seen definite improvements, and those are continuing to happen. We know that children at relapse are not all the same, and the likelihood of responding to treatment and the future for these children depends on at what time point in the treatment they relapse, whether it's during the treatment or many years off treatment, what treatment they've already received, where they've relapsed, whether it's metastatic relapse or in the primary tumour, and also the genetics and biology of the tumour. So any treatment and trials for treatment have to take all these factors into consideration. To put BEACON2 in context first, I'll talk about how we manage children with relapsed high-risk neuroblastoma and how we kind of try and approach a child where the disease has come back. So the first thing when we've got suspicion or confirmation that a child who's had high-risk neuroblastoma has got relapse disease, is that we try and consider whether we can do a biopsy of the relapse disease. And that's important because sometimes the biology and the genetics of the tumour change at relapse from the original presentation. In particular, we're looking to see whether there's any ALK mutations, because those are something that can potentially offer a treatment at relapse. We also do full staging with either MRIs or CTs, as well as MIBG scans and bone marrows. And that's because it's important to fully evaluate exactly where the disease has come back so that we can decide what the best treatment is for the child. At the point of relapse of high-risk disease, there's a number of treatment options that have been used over the last few years. Historically, people have used chemotherapy regimens with drugs such as irinotecan and temozolomide, or cyclophosphamide and topotecan. And generally, the response rates to those are low, with between 10 and 30% of children having some sort of response to those chemotherapy regimens. So over the last decade, people have tried to add on things to the chemotherapy backbone to try and make it more effective. And that has either been anti-GD2 immunotherapy, which we'll talk about in more detail, or antibodies which reduce the blood supply to tumours, so something called bevacizumab, which is called an anti-angiogenic agent, or in those patients where there's evidence of an ALK mutation, there may be a possibility to give an ALK inhibitor with the chemotherapy. And in most cases, systemic treatment with something that contains one of those options is usually the most appropriate in the first instance. We don't know which of those is the best option to use, which is where the BEACON2 trial comes in. And within the UK, we're not able to give anti-GD2 with chemotherapy outside of a clinical trial as it's not funded. So the BEACON trial not only is helping us to decide which of those is the better treatment for children with relapsed neuroblastoma, but it's also giving children access to chemoimmunotherapy or antibody with chemotherapy through the trial. Once children have had initial treatment, either with the BEACON2 trial or one of the types of treatments that I've mentioned, then they may need further treatment afterwards with some of the treatments that I've mentioned on the right-hand side. That might be MIBG type therapies with a molecular radiotherapy, CAR T-cell therapies, surgery or radiotherapy to specific sites. Occasionally, children will have haploidentical transplants and high-dose chemotherapy, or maybe early phase clinical trials. Most of those treatments are not suitable for children at the point of initial relapse, and certainly the MIBG therapy, CAR T-cell therapy and transplant, you need to have a good response to initial therapy and a reduced volume of disease before those types of therapies would be considered. And which of those treatments might be available or might be suitable depends very much on the individual child, where the disease is and how they've responded to initial treatment. Unlike initial frontline treatment for neuroblastoma, there's not a a good roadmap from the point of relapse to all the treatment that the child is going to have, because it is very bespoke depending on the child. And because this is complicated and increasingly complicated as new treatments become available, we certainly in the UK have a panel, National Neuroblastoma Advisory Panel, where most children with relapsed neuroblastoma are discussed to guide us as to which of these therapies might be most suitable for individual children. But at the point of relapse, in the first instance, our current best treatments are included within the BEACON2 trial. Running clinical trials for relapsed neuroblastoma is challenging. Although it feels often as though we're surrounded by children with neuroblastoma because we see so much of it, it is actually incredibly rare, and only about 20 to 25 children a year in the UK will develop relapsed high-risk neuroblastoma. And that means we need to collaborate with other countries in order to be able to run clinical trials properly and to get enough children recruited to clinical trials for them to deliver what they need to within a reasonable time frame. Any clinical trial ideally needs to include and test new drugs rather than just the ones that children have already been exposed to. And to do that, we need to work with pharmaceutical partners to be able to access drugs and to test those and provide data that can mean that these drugs are ultimately able to be delivered to children outside of a clinical trial. As I mentioned earlier, every child with relapsed neuroblastoma is different, and many of the trials in relapsed neuroblastoma have been done in small trials where all children have been treated with the same treatment, so there's not different arms, there's not a randomization testing different things. And that makes it really hard to compare how effective treatments are from one trial to another, because the inclusion criteria, the patients recruited to different trials may be different, and therefore the responses you see may be different. Therefore, it's really important to try and have randomized trials where children are randomly assigned a treatment group so that we know that everything is balanced between the groups, and that any differences we see in the benefits of the trial treatments are genuine and not just due to the way the patients have been recruited. So for our ideal clinical trial for relapsed neuroblastoma is one that involves multiple countries, so that we can recruit multiple patients in a timely fashion, and that is attractive to pharmaceutical partners, and that has randomization so that we can produce robust evidence of which treatment is best. And that's important if we want to be able to ultimately deliver it to all children. So the predecessor to the BEACON2 trial was the BEACON trial, and this was started over a decade ago now as the first platform trial for relapse and refractory neuroblastoma across European countries, and that was run by CEOP and the European Pediatric Oncology Neuroblastoma Research Group. So this trial opened in 2013 and initially looked at which chemotherapy backbone was best to treat relapse or refractory neuroblastoma, comparing different chemotherapy regimens, all with temozolomide but with other drugs added. It also, as well as looking at the different chemotherapy, looked at whether adding bevacizumab, the drug I mentioned, which is an antibody, which is an anti-angiogenic agent which reduces the blood supply to tumours, could be of benefit when added to the chemotherapy. And the graph on the right shows the survival data from the first part of this trial, and it shows the number of patients who have relapsed, and the arm at the top, the dashed line, shows that patients who had the bevacizumab, the anti-angiogenic agent, with the chemotherapy backbone appeared to have a more encouraging relapse-free survival than those in the other arms. When the first bit of the BEACON trial had closed in 2018, it had recruited enough patients to answer the question. The trial was amended to look at whether adding, rather than adding the bevacizumab, adding anti-GD2 antibody to the chemotherapy may be beneficial. So until then, anti-GD2 had been largely used in the context of maintenance immunotherapy. So after children had had their high-dose chemotherapy, were given anti-GD2 for a period of about 6 months. And that has been shown to improve overall survival of frontline treatment of neuroblastoma by about 15%. In that context, is given to children with minimal amounts of disease or even in remission on scans. What became clear, though, was that if anti-GD2 was actually given at the same time as chemotherapy rather than after it, then it could be potentially used for more bulky or progressive or relapsed disease. It's not completely clear how this works, but there's a number of different immune mechanisms whereby if you give anti-GD2 and chemotherapy to the child's immune system will then somehow kill the tumour cells which are coated with the anti-GD2 antibody. So what happened when the first part of the trial was complete is we amended the trial, the BEACON trial, to, rather than test the bevacizumab, to test an anti-GD2 antibodies, or dinutuximab beta, which is the most widely used anti-GD2 antibody in Europe. This ran over 18 months, just over 5 years ago, and we were able to show that by giving the anti-GD2 with the chemotherapy backbone, then we improved the number of children who responded to the treatment from 18% to 30%, and also reduced the number of children who relapsed. What you can see from the graph on the right is that the red line, which is the children who had the anti-GD2 as well as chemotherapy, initially starts off to be higher than the chemotherapy alone, but with time those graphs come together, and that suggests that perhaps you need longer treatment than the 6 months of treatment that we gave to children in this trial. So at the end of the BEACON2 trial, we'd established a platform. We'd recruited over 200 children from across Europe, and we'd found 2 different regimens which both looked promising in children with relapsed neuroblastoma. So giving the bevacizumab, or the BIT regimen, or giving the anti-GD2 with chemotherapy. Both looked promising compared to chemotherapy alone, but we didn't compare them directly within the trial. They were done at different phases of the trial. So we couldn't, at the end of the trial, we couldn't say which of those was the best treatment. During this time, people elsewhere in the world had also been testing giving anti-GD2 with chemotherapy. And for all the 4 different anti-GD2 antibodies that are being used in patients, there were studies that showed that if you give anti-GD2 with chemotherapy, it seemed to be more effective than giving either alone. And the results from the BEACON1 trial, where we gave dinutuximab beta, were largely in line with that. Our response rate was slightly lower, and but we had in BEACON, the first BEACON trial, given antibody less frequently than had been done in the American trials. We gave it every 4 weekly, and in America, a 3-weekly schedule was used. And we'd included all relapse and refractory patients, not just those at first relapse, unlike some of the American studies. And we only gave 6 cycles of treatments, whereas in the American studies, lots of the children had many more cycles. So we had a number of reasons that we thought our results may be potentially slightly lower, but also a number of things we could improve, and to hopefully try and optimize and improve the effectiveness of giving the chemotherapy with anti-GD2. So for BEACON2, which we now have open, we learned a number of lessons from BEACON1 as to how we could make it more efficient as a trial, and how we could potentially improve the treatment. So the first thing is we had learned over this time that relapse and refractory disease are really different, behave biologically differently, and shouldn't really be treated within the same trial. And relapse patients are now treated within the frontline high-risk 2 trial. And so within BEACON2, we just included patients with relapse disease. Unlike the previous trial, we divided the trial into 2 tiers, with different tiers for depending on how many previous relapses children had had. And so for the children where it was their first relapse, we looked at just directly comparing anti-GD2 chemoimmunotherapy with BIT, the bevacizumab regimen, which had also shown promise in BEACON. In addition, we were keen, although both of those strategies have shown some improvement compared to chemotherapy alone, both of them are still disappointing compared to what we'd really be like to achieving in children with relapsed neuroblastoma. And so a key aim of the trial is to not just work out which of those is better, but try and improve it. And to do that, we've incorporated the ability to test new drugs within the trial. So this is the structure of the trial. The two tiers of the trial. So tier 1 is a randomization, so children are randomly allocated to one arm or the other, and this is for patients with first relapse of neuroblastoma, and children are either allocated to anti-GD2 with irinotecan temozolomide chemotherapy, so that's dinutuximab beta with irinotecan temozolomide, or BIT with bevacizumab irinotecan temozolomide. If children have had more than one relapse, then they are eligible to be recruited to tier 2, and this is the platform to test novel combinations of treatment. And to start the trial, we, rather than put the chemotherapy with either dinutuximab beta or bevacizumab, we put the chemotherapy backbone with both of those together, so-called DB-BIT arm, to see whether, if both of them improved the effectiveness of chemotherapy, would there be benefit of giving both together. The plan then is, if the small numbers of children recruited to the small tier 2 arms are safe, if the side effects are tolerable for patients, we don't see anything unexpected when we combine them, and we get a signal from how children respond that there's some benefit, we will then incorporate the new regimen into tier 1 and include it in the randomization to get definitive evidence and data as to whether that new regimen is effective. So it's a platform that's dynamic. It starts with these 3 arms, but the plan is that we can introduce new arms to both tier 1 and tier 2, so that new things that come from the lab and new combinations of treatment can be introduced into tier 2, and if they look promising in tier 2, they then can be taken into tier 1 and included in the randomization. As Alan said, it's a multi-arm, multi-stage randomized trial, and that means that it does this early phase testing of the new combinations, but also is doing the randomization, testing the regimens which we already have tried and tested, but not directly compared with each other. The overarching aim is to improve outcome and survival for children with relapsed neuroblastoma. But as well as just looking at the survival, we're also collecting data about the quality of life of children on the trial. All of these treatments are intensive and all require time in hospital and have side effects, and it's really important that we know what the impact of that is on children and families during the treatment, and to weigh that up with what benefits we see in terms of impact on the neuroblastoma. In addition, we're collecting biological samples from children from bone marrows and tumour before, during, and at the end of the trial to see whether we can predict which children will respond better and to understand better how these treatments are working. The trial, the BEACON trial, the first BEACON trial had 10 countries. We've expanded in BEACON2 to have 18 different countries so that we can recruit quicker across more countries. The trial is led by and sponsored by the University of Birmingham, and it opened in the UK in November 2024, and it's now open across the vast majority of UK sites. It's just opened in Australia, and we've got regulatory approval in the rest of Europe, and we hope it will open in other European hospitals very shortly over the next few weeks and months. The first tier 2, which was testing the double combination of bevacizumab and dinutuximab beta with chemotherapy, has actually recruited really well and has just recruitment last month. It is an academic study, so it's run by the University of Birmingham, but we've worked really hard to try and make it attractive to pharmaceutical companies so that they will bring their new drugs to us so that we can incorporate and test them within the trial. And that's an advantage for us and for children to get access to new drugs, and also to the company to be able to have a pathway where they can test new drugs and take them hopefully eventually to a marketing authorization so they can be prescribed and used outside of a clinical trial. Not all children are eligible for a clinical trial, but we hope that most children with their first relapse of high-risk neuroblastoma will be eligible for tier 1 of the trial. Those who have had more than one relapse, the current tier 2 is just closed, but we hope we will be opening the next tier 2 over the next few months. But for any child recruited to a clinical trial, it's important they are fit and healthy enough to be able to have the trial treatment. And so there's some criteria on blood tests, such as platelet counts, blood counts, and renal function, liver function, that must be above a certain threshold to be eligible. And those need to be at the time of trial entry to make sure that those are current and the child is fit enough to take part in the trial. At the beginning of the trial, children have to have complete staging with MRI scans, CTs, MIPG scans, as well as bone marrow aspirates and trevines, and also to be examined at one of the trial centres. The trial treatment is given every 3 weeks. So for the dinutuximab beta arm, children are given the anti-GD2 as a 7-day infusion, and with 5 days of antibody, irinotecan and temozolomide, which runs alongside that. For the bevacizumab or BIT arm, children get just a single dose of bevacizumab on the first day of the cycle, and then the 5 days of chemotherapy, and that's repeated every 3 weeks. Unlike BEACON, which we gave 6 lots of cycles of treatment, we've extended this because we think longer treatment may be beneficial, and children are able to have up to 12 cycles of treatment on the trial. That doesn't mean they have to have 12 cycles. If it's deemed to be more appropriate for them at some point to come off the trial, then of course they can come off at any point. Because it's a trial, there is some mandatory assessments of both to look for side effects and toxicity of the treatment, but also to look at the response of the disease. And that's initially every 2 cycles. Children have to have scans and restaging, and then every 3 cycles, and once they've had a few cycles of treatment. In order to get really robust data that can be used to change the regulatory status of the drugs that we're using, all of the scans and bone marrows are going to be centrally reviewed, so that we know that the data from them is really robust. So for any child taking part of the consent is that there's agreement that any scans and bone marrows can be sent to be reviewed externally. And as I mentioned, quality of life assessments and biological studies are key components of the studies and are repeated periodically throughout the study. So tier 1 of the study, which is the randomized arm for children with first relapse of disease, has recruited 16 patients so far of the planned 150, and hopefully that will speed up once we have more countries opening over the next few weeks and months. And the first tier 2 completed recruitment last month. As I mentioned, it's a dynamic platform, and the idea is that we introduce new tier 2 arms as we get new treatments from the lab that we think warrant testing in children with relapsed neuroblastoma. There's lots of different potential mechanisms by how anti-GD2 can kill neuroblastoma cells, either alone or with chemotherapy. And that can either be by enhancing any of the different immune cells which we think may be involved. And there's things like natural killer cells or macrophages or T cells, which there are a number of drugs that are available that potentially have the ability to improve the function of those immune cells. And there's also drugs that can just modify the immune environment in the neuroblastoma to make it less immunosuppressive, less unfriendly to immunotherapy, and make immunotherapies more likely to be effective. Or things that may just sensitize tumour cells to being killed by the chemotherapy or the immunotherapy. So the next tier 2 that we're planning is come from some colleagues based in Sydney, and they have actually been looking at a drug that's already used in children with Wilson's disease, which is a very different, it's not a cancer, it's a problem with copper storage. And these children have too much copper. And the drug that we're looking at testing is a drug that gets rid of this copper and reduces the amount of copper in these children's bodies. And what Orazio Vittorio and his colleagues in Sydney have found, that if you give this drug to neuroblastoma cells and in preclinical models of neuroblastoma, then getting rid of the copper, reducing the copper, actually has lots of beneficial effects on the immune environment and makes the immune cells more able to kill neuroblastoma, brings in more immune cells into the tumour, and makes anti-GD2 immunotherapy more effective in mice. And so based on this, we're hoping that we can test this within BEACON2 by adding it to the chemoimmunotherapy backbone. The good thing is that this drug, triatine, is already used in children in this disease called Wilson's disease, and we know it's safe and well tolerated in children with this disease. And it's already it can be taken by mouth, and because it's already been tried in children, that makes it a little bit easier to take it into a trial in neuroblastoma. It's also been used in some adult trials with a similar aim of trying to make the immune environment more friendly for immunotherapy, to make immunotherapies more effective. There's also a number of other combinations of treatment which have been identified by the new drugs and immunotherapy committees within the European Research Network that all have the potential to either enhance chemoimmunotherapy or to just be effective treatments for relapsed neuroblastoma in their own right. And what we are doing regularly within the CEOPN community and meetings is to hear updates on all these potential treatments and to prioritise which we think is going to be most, should be the priority for taking into children including within the trial. And so we hope, because these things take a little while to move from the preclinical work to the clinic, that if we identify things when things are still at the laboratory stage, we can have a pipeline whereby we've got the next 2 or 3 arms ready to take into clinical trial and to test and give to children. This has been greatly enhanced by an opportunity that Solving Kids Cancer has provided, whereby they're providing some funding support to research scientists to try and develop new combinational therapies in the laboratory to provide the data we need to be able to take them into clinical trial in children within the BEACON2 trial. So to conclude, both the BIT and the GD2 chemoimmunotherapy regimens have shown promising activity in the BEACON trial, although both of them we would like to see more effective treatments for children with relapsed neuroblastoma. The first tier 1 of BEACON2 will directly compare these 2 arms, and that will be for patients with first relapse of disease. And then for patients who've had more than one relapse of disease, we have a platform which we can now test novel combinations that haven't been tested before, that have shown promise in the laboratory, and to see whether those are safe and tolerable in children, and whether we see any signals that they are effective in children as they are in the laboratory. If they do, we can then promote them to tier 1 and test them robustly within the trial. So certainly within the UK, now that we've got BEACON2 open, this would be our first recommendation from the majority of children with relapsed neuroblastoma. If they're eligible for BEACON2, we hope that it's a very good option for children to take part in, and it will hopefully benefit not just the children taking part, but future children who will, that with the information that we will learn from them taking part in the trial. It is a platform, and we hope it will evolve to incorporate all the exciting preclinical combinations which I mentioned, so that we can respond as the science develops. We can respond and take things into clinical trial relatively quickly. I think I will stop there, and very happy to answer any questions. But just before that, just to thank all the children and their families who've already taken part in the trial, but also to the team, the large team of people who helped make the trial happen, and also all the charities, particularly Fight Kids Cancer, who have financially supported the trial. I think I will stop sharing then, hopefully.
Yeah. Thank you, Professor Gray. Very interesting, insightful presentation and some great explanations in there about the strategy behind BEACON2. So we've had a really active Q&A session online. Some are really well articulated and some have common themes. So what I'll try and do is I'll try and get commonality between the questions and ask Professor Gray to answer. So let's start at the introduction end. So Professor Gray, you mentioned there's been significant improvements in outcomes for relapsed neuroblastoma. What kind of percentage improvement has there been? And what do you think personally has made the most positive difference?
So the second bit of that is probably the easiest bit. The addition of anti-GD2 to chemotherapy has been the biggest stepwise change in outcome for children of neuroblastoma in recent years. It's really hard to give a percentage change in improvement in outcome. For any trial, the most immediate measure of how effective the drug or the treatment is how many children have tumours that respond, that shrink with the treatment. And that has certainly improved with combinational treatments such as chemotherapy, with many trials reporting response rates of between 30 and 50%, or even some slightly higher, whereas with chemotherapy alone it was lower than that. It's really difficult to capture data of what happens in the long term to those children because they go on to other trials or have other treatments, or the follow-up from the trial is not so long term. What I can say is though that there are now children surviving for many years from relapsed neuroblastoma, whereas when I first started doing paediatric oncology, we just didn't see that at all. And children, we didn't have these options to give children. It still feels like a really challenging situation, but we do have options now, which we didn't have 15, 20 years ago at all. And over the last 5 to 10 years, I've definitely seen improvements in what the therapeutic, the trials we have to offer and the different types of treatment.
Thank you for that, and I agree. Going from no options to what we have has been significant for us as a parent population and a patient population. How do you think we could speed up development of new treatments for relapsed neuroblastoma, given everything that's happened so far and the improvements that we made today? And more importantly, what can we do as a parent community to support that progress?
Excellent question. So I think having a platform trial is a really good thing to speed up progress, because it means when you have a new treatment, you can amend the platform to include it, which is much quicker than setting up a new trial from scratch. It is still frustratingly slow. It's quicker than setting up a new trial. And what I think we can do as a community is work at how we can set up clinical trials quicker, and that's partly the setup in the central setup at Birmingham or wherever's running the trial, but also opening in every hospital in every country, and all of those stages in the process take time, and there is work to be done to try and reduce the replication of that and to make it smoother and quicker. And I think as a community, which includes both parent advocates and clinicians and charities, we can get better at that.
Thank you. Following on from that, there's a question. It's related in part to what you just explained about what the parent community can do in terms of opening in more centres. But one of the questions was, why do you believe that Tier 1 has been slow to enrol for BEACON2?
So we've only had the UK open until Australia opened last week, and within the UK it's been open about 15 months. Within that time, we would only expect between 20 and 25 patients with high risk neuroblastoma to relapse, and not all of those will be eligible or will want to or be fit enough to take part in a clinical trial. So it will be much faster when we've got all 18 countries open.
Okay, thank you. You mentioned there at the end, not all children will be eligible to take part in clinical trials, not only in Beacon, but in any clinical trial. Maybe you could give us a high level in terms of how eligibility criteria are designed. And if a child isn't eligible for Beacon2, what else could they do? And very specific to Beacon2, is GD2 positivity entry criteria for Beacon2?
So I'll answer that bit first. So we don't currently check GD2 expression on tumours, and we don't actually mandate or insist that children have a biopsy prior to going on the trial. We can use historical biopsies that they had at first diagnosis if it's not deemed to be clinically needed for them to have a biopsy. I think as we're using more and more GD2 targeting therapies, including CAR T cells and anti-GD2 and other things, it is becoming more important to look at GD2 expression and to see whether that does, whether tumours do lose that if you give lots of different GD2 treatments. And so we are doing some work as to how we can routinely test it in tumours at children at relapse or during frontline treatment. It is quite complicated, the technicalities of it, and to make sure it's consistent. And we also need to make sure that we know how to interpret the results, that we don't exclude children from trials because expression's not quite as high. We don't know what level of expression you need to be suitable for anti-GD2 therapy. So it's a big piece of work that we're doing both within the European network, but also with colleagues in America to try and find out what test is better and to introduce that into trials. The other question you asked was about eligibility generally, and sometimes children with neuroblastoma, the neuroblastoma will come back really aggressively and quickly, and children are really sick at the point of relapse. Because it's a clinical trial, we need to do all the staging tests, the scans, the MIBG scans, the bone marrows before they start the trial treatment, because otherwise you won't know whether, if you don't know what disease is there at the start of treatment, you won't be able to tell whether the trial treatment has worked. And some children are not well enough to have all those tests done before having any treatment, because that can take a couple of weeks to get all those things done. Or some children, unfortunately, have problems with their kidney function or liver function or bone blood counts that mean they're not eligible. For those children, I think it's an individual conversation with the child's doctor and team as to what's the most appropriate for the child, depending on how unwell the child is. But sometimes it's possible for children to have some non-trial chemotherapy first to try and stabilise the situation, and then repeat the scans and see if they're eligible for the trial.
Okay, thank you very much. More questions coming in here. How do parents find out where Beacon is currently open or is likely to open? Do they approach sponsors directly, or do they talk to their oncologists themselves?
So it's probably better to talk to their own oncologists themselves, and certainly within the UK now, we've got the there's only 2 paediatric oncology centres that aren't yet open, and we're very happy to accept children from other centres if need be. I think most paediatric oncologists at all centres across the UK will know about the trial and know where it's open. Across Europe and outside of the UK, it is probably best to approach their oncologist, who can always contact the sponsor.
Okay, thank you. A specific Beacon2 question here. During treatment on Beacon2, are children with an ALK mutation permitted to receive an ALK inhibitor?
Good question. They can't, because it's a clinical trial, and it would be difficult if the child was having another anti-cancer drug like an ALK inhibitor as well as the trial treatment, and then they had a significant side effect. It would be hard to know whether that was a trial treatment that had caused that or the ALK inhibitor. And there's relatively limited experience of giving ALK inhibitors with chemoimmunotherapy. So the children can have that before going on BEACON2 trial, or they can have it after, but they can't have it at the same time.
Okay. I think you may have answered this during the presentation, but just to get a yes or no from you, in BEACON2, is it only for first relapse or for subsequent relapses? And you talked about the tier 2 trials, so maybe you give us a quick answer on that one.
Yes, so it is for both, but at the moment there isn't a tier 2 open because it's just completed. So we're just working on opening the next tier 2, which we hope will be the copper collator arm.
Okay. And just while we can't specifically address individual cases or patients at this, maybe a general question. If BIT is hard to tolerate, what practical supports or adjustments can we put in place to help the child tolerate the treatment better?
So the irinotecan can cause diarrhea, and so there are some strategies to try and reduce that. Was it about the anti-GD2 side effects or the BIT side effects?
BIT side effects specifically.
So my experience has generally been that BIT is usually quite well tolerated, and the major side effect that we see is diarrhea, and that is under some circumstances we can change that. So instead of irinotecan, we change to topotecan, which is a similar chemotherapy agent but with less diarrhea. But sometimes we use drugs which reduce the diarrhea or give preventative antibiotics to prevent it. So there are strategies to try and improve that.
Okay. Two potential questions about the potential future of BEACON2. Are there any future plans to include children with refractory disease? And perhaps you can talk about the types of scans used and which are deemed better or worse. And that's a tough question in terms of MIBG versus PET, but maybe you can give us a little insight there. Thank you.
So there aren't any plans to include refractory patients. They behave differently and respond differently to treatment to relapse patients, and they are now included within the frontline COP and HR2 study, and so it makes the data quite hard to interpret if you include both in the same trial, because if a new treatment doesn't work in both groups, you may lose seeing the effect in the whole group because it's diluted by not working in one group or the other. So we plan to stick with it just being a relapse platform. And what was the other bit of the question was?
The scans.
Scans. So for the trial the protocol is quite specific about which. So MIBG scans should be done on everybody unless the tumour doesn't take up MIBG, and about 10% of children will have tumours that are not MIBG avids, don't take up MIBG, and those children need to have an FDG PET scan. But we can't do PET scans just because we want to. They're only done in children where they're MIBG negative, and then MRI or CT scans depends on the local clinician's decision as to which is most appropriate to assess the tumour in that child.
Okay. I'm going to maybe have to interpret this question a little bit, just the base. Are there any trials assessing the potential for neuroblastoma stem cells to see if they're triggering a relapse? So I guess this is after transplant. We know that we don't clean cells, etc. So is there a thought that may be a potential source of relapse, and is there any plans to address that? I hope I caught that question correctly.
Yeah, I don't know. I mean, people have looked in preclinical work at stem cells and kind of the role in kind of relapse. I don't know of any clinical trials that are addressing that. Although one of the things about the Beacon and BEACON2 platform is we're collecting a huge amount of biological data, and there's a possibility to look at that data and to try and mine it for quite. It's a big resource, and that can be correlated with the clinical outputs from the trial to try and answer kind of specific questions like that. Okay.
We've come to the last documented question, so I'll ask this in a few minutes to add to the chat and keep Professor Gray under pressure here. So for BEACON2, is the goal mainly to shrink the tumour to enable another treatment or stabilise disease? And maybe you can talk a little bit about the mode of action of bevacizumab in that. And what do children normally move on to if they're not successful? I guess we're early in BEACON2, but what's your opinion on that?
So I guess this is, if you've got a child with relapsed tumour and you go on to the BEACON2 trial, the tumour will either stay the same and have stable disease, it will get worse, or it will get better. For those children where things are getting worse, then clearly there's no point carrying on with the same treatment. And then for those children, then we need to look at different options, such as early phase clinical trials. For those children who the disease is stable, we think there is some value in giving at least 6 cycles of chemotherapy to try and maximise the chances of seeing benefit. For those children who have a good response, then there are options as to what you can do afterwards to try and consolidate that and reduce the risk of further relapse. But there is no good evidence to guide which of those is the best. So things like MIBG therapy, CAR T cells, repeat transplant are all things that have been used in different parts of Europe. And it's really difficult to interpret the results of those trials because you're doing, for instance, say you give CAR T cells to a group of children who've been through Beacon and have a good response. You're giving the CAR T cells to a group of children who responded well. It's not to all children who relapse. So you're giving it to the good players. And to try and interpret what that means then, if what would you expect those children to do without that treatment is really hard. And so those sort of treatments can all be discussed and considered on an individual basis. None of them are particularly easy treatments in terms of practicalities and geographical availability, and some of them have a cost, and some of them are not available all the time. So in practice, there's often not all of those options available to any child, and it may be more driven by availability and practicalities as to what the options are. In the future, we hope there might be a trial to compare different consolidation type therapies. That brings us with it a whole kind of raft of different challenges. But what we would really like to do is to try and compare those and see which of what should you do if a child has had a good response to the BEACON2 type treatment. What can you go on to next? And in principle, you can kind of sort of replicate the initial treatment that you have, an initial sort of induction treatment with good shrinkage, and then you give some consolidation, which is high dose chemotherapy in frontline treatment, and then some sort of maintenance treatment. And there are, the things like CAR T cells and MIBG are kind of types of consolidation treatment that could be used instead of giving more high dose chemotherapy. And DFMO and vaccine are things that potentially can be used as a maintenance type treatment, but it's really hard to know what the benefit of those is because the trials comparing them with other things just hasn't been done.
Okay. Now we've one late. What is your opinion, or what are your thoughts, more accurately, on haplo?
So haplo transplants is it's been done mainly in Germany within Europe, and our colleagues in Germany have got a lot of experience of children who had initial chemotherapy, and most of them then MIBG therapy, and then gone on to have haplo transplant, which means rather than with standard high dose chemotherapy that children get during frontline treatment, they get their own stem cells back. With a haplo, it's half matched, and you get it from either your mother or your father. And then after the haplo, they get anti-GD2. And so there's a lot of different factors involved there with the treatment they get. They get chemotherapy, the MIBG therapy, the high dose chemotherapy with the transplant, and then more GD2. They do report some encouraging results, but it's hard to dissect out what the benefit of the haplo transplant is within that. But what we do know is that any transplant, any high dose chemotherapy, has lots of side effects. Inevitably, it's several weeks in hospital with nasty mucositis, a risk of significant risk of major toxicity, which can be life threatening. And so we it is an option, but we don't know how that compares with other options such as MIBG therapy or CAR-Ts or other things. It's not routinely done within the UK, but it's more in other countries such as Germany that it's been done.
Okay. That's all we've got time for, I'm afraid. I'd like to just take this opportunity to thank everyone who's joined us for today and for the questions. The standard of question coming is fantastic, and clearly a very engaged parent population, which is great to see. I'd also like to thank Professor Gray for that talk and also for everything you do on a daily basis. To thank United Therapeutics, Norgine, Recordati Rare Diseases, and Y-Mabs Therapeutics for their support of this webinar series. I'd just like to remind you that this seminar has been recorded and you'll be able to watch it back at any time. We also hope that you'll be able to join us next Thursday for the 4th webinar in this 6-part series. The topic of that webinar is going to be the MINT study, addressing unmet need in high-risk neuroblastoma, with the speakers Dr. Sally George and the parent advocate Helen McCarthy-Tennant. Thank you very much for being with us today, and take care.